Let's start to another topic, another interesting one that's about tuberculosis children in the management of ocular tuberculosis by Dr. Shalina Oli Muhammad. She's graduate fellowship from Moorfields Eye Hospital in UIT's division. Please welcome to her.
Thank you. Good evening, everyone. I would like to share from my country on this topic, the resurgence of tuberculosis and the challenges in the management of ocular tuberculosis in Malaysia. As we know, tuberculosis is a rising concern globally and in our countries as well, not just in Malaysia, I think it's in the region. The WHO reported an increasing number of TB infections. Mainly, a few factors were identified, firstly due to multi-drug resistant TB, with the increased incidence of HIV and also global migration. And in 2010, globally, there were 8.8 million new cases of tuberculosis, and in our local Malaysian incidence, it was 81.4 per 100,000 population. I'm sure this is a common problem that we are all sharing. If we look at the WHO report on the estimated incidence of TB in 2010, the darker the green color goes, the more the incidence of TB in that particular country. And we can see that our countries here are not left out, and many of our countries are in the darker versions of the green. So this is a problem that we will all be facing actually. And in 2001, in my country, TB was the second most commonly notifiable communicable disease after dengue. So this is from our clinical practice guidelines, whereby the notification of new TB cases in Malaysia was reported between 2005 and 2011. And when we see in 2005, if we total this, it was about 15,000 cases, and this rose to about more than 19,000 cases in 2011. And as for the eye, which is extrapulmonary TB, it comes under extrapulmonary TB, and we can see the blue color graph is also rising, which indicates that there is an increase in extrapulmonary TB as well. This is the map of Malaysia. We have the peninsula and also East Malaysia, and looking at the states, we find that this state, Sabah, has had the highest incidence of TB, followed by the state that I come from, Selangor, which is very close by to Kuala Lumpur, and that's one of the most densely populated in our country, and that's why there's a high incidence of TB there as well. In looking at the data globally, the prevalence of TB as an etiology of uveitis, of course in the Western countries it's very low, and as we come to our region, the incidence is very variable. Some are high and some are not so high. This is probably because the true prevalence is very difficult to collect the data, because the diagnosis of ocular TB in our regions is all very variable. Okay? So the way that they report the cases and the way the data is collected with the diagnostic criteria is very variable. That's why the incidence is quite variable across the region and across the globe. So in the hospital where I work, which is Hospital Selayang, it is the main tertiary national referral center for uveitis in Malaysia, and there we did a short study which between 2014 and 2015, and we found that infectious type of uveitis was comprising about 70% of all uveitis cases, and out of that 9.54% were diagnosed with intraocular TB. Intraocular TB means the uveitis, TB due to uveitis. So actually, globally, there are many challenges in the diagnosis of intraocular TB, which I'm sure my colleagues here are also sharing the same problems. So firstly, the lack of active systemic signs. When patients have TB in the eye, uveitis, tuberculous uveitis in the eye, usually they are otherwise quite well. They usually have only latent TB and no active systemic TB, usually in most of the patients. The second thing is that there is a wide spectrum of clinical signs, which I will discuss later. Thirdly, we don't have a standardized consensus treatment guidelines for the management and diagnosis of intraocular TB, and also the diagnostic tools. Not all the tools are available in our countries as compared to West and the more developed countries. So intraocular TB is an extrapulmonary manifestation of TB, It is usually not associated with clinical evidence of pulmonary TB, and in a study they found up to 60% of extrapulmonary TB patients may not have pulmonary TB, and about 1.4 to 6.8% of active pulmonary disease only had concurrent ocular TB. This makes it even more difficult for diagnosis. So the first challenge that we face in our country is the lack of understanding about this condition by our physicians. As we know, the disease, once diagnosed by the ophthalmologist, we look upon our physician colleagues to start the treatment. So I give you an illustration of a case of a 23-year-old medical officer who came to us with blurring of vision in the left eye. He had fever and cough. The MEN2 test was 18 millimeter. Chest X-ray was normal. All other infective screening was negative. So the vision in the right eye was normal, and the findings were in the left eye. The vision was counting fingers at 1 foot. There was a granuloma at the optic disc. There was optic nerve dysfunction, reduced color vision as well, and RAPD. So we made a diagnosis of left neuroretinitis secondary to ocular TB, and we looked upon our physician colleagues to initiate the anti-TB treatment as soon as possible. However, they were not convinced with this. I'm sure we are all facing this similar problem, and they proceeded to do an urgent CT scan brain, and then they felt that probably the patient was having meningitis. The patient went through a lumbar puncture, and then they were not convinced. They wanted to further investigate. So finally, the treatment was commenced by the ophthalmology team, where we started the 4 anti-TB drug EHRZ treatment, including ethambutol, and finally, following that, we started on systemic steroids, and we can see even at day 3, we can see that there's already improvement, and subsequently the vision also improved, and the patient attained 6/9 vision. So that is the first challenge, which I think I share with my other colleagues here in the room as well. The second challenge is the delay in diagnosis by our general ophthalmology colleagues, with resulting in late referrals for initiation of anti-TB treatment. Because it's an inflammatory disease, very often these patients are given courses and courses of steroids, where you taper down the steroids, then they relapse, and subsequently until the patient starts developing the complications. So that results in poor visual outcome. So as we know, TB is actually intraocular TB. Actually, it has 2 modes of transmission. One is direct infection via blood dissemination through the blood, and it reaches the eye, forming like a large granulomas in the choroid. Okay, you can see this on the OCT. You can see the choroidal elevation here, and the resulting fluid. Okay, the second mode of transmission is through the second mode of inflammation in the eye. Actually, is through hypersensitivity reaction to the bacillus. The bacillus may be located elsewhere, and there is a hypersensitive reaction in the eye, resulting in intraocular or tuberculous uveitis. So as for example, in Eagle's disease due to TB, you can see vasculitis, occlusive in nature, where there is new vascularization and hemorrhage, pre-retinal hemorrhage, and that is believed to be a hypersensitive reaction to TB bacillus elsewhere in the body. So in a recent major review by Professor Narsingh Rao and his colleagues, they tried to subcategorize the uveitis, the pattern of uveitis that TB can present with. And we can see here there are 6 different ways TB can present intraocularly, either anterior uveitis, intermediate, posterior and panuveitis, retinitis, vasculitis, neuroretinitis, and a very severe form would be endophthalmitis. So I've just put up some patients of ours who have had all these problems. We can see anterior uveitis, we can see granuloma on the disc with neuroretinitis, multifocal choroiditis, which is posterior uveitis. This is another posterior uveitis. This is serpiginous choroidopathy, which is another form of posterior uveitis, believed to be hypersensitivity reaction. This one as well I showed earlier, and this is also posterior uveitis. So with so many variable presentation of TB, sometimes we get confused, okay? And so we need to create awareness among our colleagues when they see these kind of patients with these kind of signs and symptoms, to refer the patients immediately to centers which can manage them as intraocular TB. So the third challenge, which I think most of us here are facing, is availability and accessibility to immunological tests for the diagnosis of intraocular TB, which is limited in our country. So what is actually available? Basically, The tuberculin skin test or the MEN2 test, I think, is the age-old test that we are all doing in cases of uveitis, and it's still in fashion for most of us here. It's cheap, it's routinely used, it's widely used, but the problem is actually in our region as well, which I think we are all facing, whereby in TB endemic countries and in Malaysia, all our population receives BCG vaccination, and there's cross-reaction with MEN2 tests, and you can get false positive results. So that may affect our diagnostic ability for TB and probably make it, there will be more false positive cases. The other thing is the MEN2 test cannot distinguish latent from active TB. It has really high sensitivity but very low specificity. So we might be overdiagnosing TB if we're just looking at the MEN2 test. And false negative is also an issue, especially in patients who have HIV or who are immunocompromised. So there are other forms of tests. This is the interferon gamma release assay, if you've heard the quantiferon gold test or the TB spot test. This in one of our Professor Chin Soon Pek, who is of uveitis specialist in Singapore, she conducted a study looking at the use of quantiferon test, which is more specific than the MEN2 test, but is not more sensitive. So she felt that these two tests should be performed in each patient and interpreted together. We get a higher specificity in the results. Likewise, the TB spot test is also an interferon gamma release assay. It's taken through the blood, okay, where there is no cross-reaction with BCG testing. It's more specific. And she also reported that, it's highly likely to be intraocular TB if both the MEN2 test and the IGRA or this interferon gamma release assay test are positive. However, the major drawback for us all is these tests are expensive. In Malaysia, it costs about more than $100 per test to perform this test. It's not widely available, and we cannot subject all our patients to this test, so we still fall back to the age-old MEN2 test. I think, I'm sure all of you have the same problem. So we move on to the more definitive diagnostic tests like the polymerase chain reaction test, which has been reported by colleagues, especially in India, where they take the aqueous fluid and the vitreous fluid and look for multi-targeted genomes of the TB mycobacterium, and they found that the specificity goes up to 100%. So this is one of the best ways to diagnose intraocular TB or TB uveitis, and a positive predictive value of 100%. However, it's expensive. You need very special labs to perform this, you need expertise, and of course cost is an issue even for us as well. And the best way to diagnose any TB would be to take samples or biopsy, but of course being a paucity very nature of the disease, and our echo sample being having low sample value, so low sample volume, possibly, and also the possibility of the hypersensitivity reaction. This is very poor way of testing currently. Even imaging. In our uveitis patients, we subject our cases to a chest X-ray. All patients will go for a chest X-ray, and it can be normal in up to 70% of patients with TB. The high resolution CT thorax can pick up hilar lymphadenopathy much better, but of course it's expensive as well. Some have reported the use of PET scan. They found that it can be positive in 45% of IGRA positive patients, where they can pick up hilar lymphadenopathy, especially in these two entities of intraocular TB. In a retrospective study that we conducted in our center, totaling about 386 patients identified with intraocular TB, after exclusion, whereby those cases which we felt the diagnosis was not accurate, or whereby the vision and there were other ocular comorbidities and difficulty in assessing visual outcome. After excluding them, we had 146 patients with 219 eyes that we looked into, with a mean duration of follow-up of 31.74 months. So we looked at the way how are our patients being investigated for intraocular or tuberculous uveitis. So all our patients, 100% that were included in this, had a MEN2 test of more than 10 millimeters or more, and about 52% had a MEN2 of more than 15, and only 19 patients we could afford to do the highly specific IGRA test. out of that 15 were positive, and in performing of PCR, only 9 patients had the opportunity for us to send the intraocular fluid samples for PCR testing. However, our PCR test was very poorly sensitive, and only 1 out of the 9 patients were positive. So this is our local scenario, and probably the scenario that you all may also be facing. So the fourth challenge, looking at that data, is that our diagnosis is mainly presumptive and not a definitive diagnosis. So probably we are overdiagnosing our patients. So in looking at the latest recommendation for diagnostic criteria for TB, intraocular TB, whereby confirmed intraocular TB is when there is positive PCR or a positive culture, and presumed ocular TB is when there are signs of TB with either a positive MEN2, chest X-ray positive, or any other extrapulmonary TB lesion, or a positive therapeutic trial of anti-TB. This is what we are using most of the time for diagnosis, whereby we have signs and symptoms of TB, a positive MEN2, and the patient responds well after 6 months or so, of at least after 4 weeks to 6 weeks of anti-TB, we can see the response already. So in our study, we found that 145 eyes were all of presumed TB, and only 1 had a definitive diagnosis, that 1 patient that had the positive PCR. In looking at the more revised criteria recently published in the Ocular Immunology Journal in 2015, whereby they subcategorized it to confirmed cases, probable or possible. Still, our patients are all in the possible group. Probable is if there is a previous, at least 1 clinical sign with a TB lesion on chest X-ray, and at least 1 exposure to TB, or a positive MEN2 test, and we had about 10 patients in that category. So still again, we are still diagnosing our uveitis, TB uveitis patients using this kind of criteria, whereby most of our cases are possible intraocular TB. So the fifth challenge is the absence of consensus guidelines for diagnosis and management of ocular TB. As we know, so recently in 2012, in Malaysia, we had the clinical practice guidelines for the management of TB. Of course, in these chapters, there was a chapter on extraocular TB, but there was no specific chapter on TB in the eye per se. But in the West as well, in the Canadian, American, British, and South African national TB guidelines, also there's not much information on ocular TB diagnosis or recommendations on treatment. So we share the similar problems globally as well. And recently, in his paper by Professor Chi Soon Pek in VDO, she also mentioned that there's no consensus on terminology guidelines on investigative tests and treatment with TB drugs as well as steroids for the management of ocular TB. So we are also facing similar problems in our region. So in looking at our group of patients, out of the 146 patients, initially the anti-TB regime that we were treating, because we had a lack of cooperation from the physicians, we took it into our own hands and we started giving our patients just the HRZ treatment. Later on, we learned that we are promoting multi-drug resistance, and now we've started initiating our patients on the 4-drug regime. More and more of our patients are receiving that. And in looking at the duration of the anti-TB treatment, there is one paper that mentioned that the outcome is better with less relapses if you give the patients 9 months treatment compared to just 6 months treatment. So, but there's no specific guidelines on this. So our patients mostly were receiving 9 months of anti-TB treatment. So the consequences of a lack of guidelines would be delayed presentation, inaccurate diagnosis. We may be over or under-diagnosing our patients, inappropriate empirical treatment. As you can see what we were doing also, we were only giving the 3-drug treatment, and high treatment default rates. So the sixth challenge and the final challenge that I would just like to share with you is on the diagnosis and management of Tb hypersensitivity. So it's the diagnosis and management of Tb hypersensitivity, which is still unclear to most of us, and the risk of overdiagnosis, whereby a lot of patients with inflammation in the eye, we start them on steroids, then we think the MEN2 is positive, it looks like TB, we give them TB treatment as well, but we are not sure, is this really a hypersensitivity, Tb hypersensitivity, or is it just a normal intraocular inflammation or an idiopathic or a non-infectious uveitis? So TB hypersensitivity and the role of systemic steroids is still unclear. It presents with uveitis in latent TB patient. There's no specific diagnostic criteria still, and we give a combination of anti-TB and systemic corticosteroids, which will help reduce the recurrence. And it's reported that there's an 80 to 85% chance of eliminating recurrence in when you treat patients with hypersensitive TB with anti-TB as well. However, there are no clinical trials on the efficacy of steroids in ocular TB, and it may be used to complement anti-TB regimen to reduce the sight-threatening inflammation and vasculitis. So in summary, the resurgence of TB has led to a significant increase in intraocular TB, but the complexity and variable nature of intraocular TB makes it a challenge for diagnosis and treatment. And a major unmet need is the standardized guidelines to guide us with the treatment, to avoid over-treatment and exposure to side effects and reduce the risk of drug resistance. Thank you very much. I would like to invite you all to Kuala Lumpur next year for our 6th Indo-China Ocular Inflammation meeting. And also that will be followed by the very next day, it will be the 11th APVRS conference in KL. Thank you.
Hello. Any questions from the floor? Thank you very much, Dr. Shalina. I would like to ask the Associate Professor Kapua to present the gift to Dr. Shalina.